as soon as is possible, because you are not really bothered about any weight that is placed on this affected lower extremity. Okay. But many a times, if the patient is not able to sustain the extra cost of walking, so because we are looking at an additional upper extremity contribution, we are looking to into the use of an assistive device, we are looking at even hopping around. Okay, so non-weight bearing is essentially the patient has to jump around and they need to have good upper extremity strength. So if they do not fulfill these prerequisites, if they have some underlying cardiac conditions, or if they are elderly, if you feel that the opposite lower extremity is not strong enough, then in that case even the non-weight bearing phase has to wait. Okay, but otherwise in most of the individuals we will want to start off with some weight bearing, at least on the opposite extremity. So for the affected extremity they will continue to be non-weight bearing for some time. Okay, the other factor that mattered was the type of fixation. So we had said that for the stress sharing fixations, as soon as some callus formation is visible, weight bearing may be initiated. Remember, I had also spoken about dynamization of a stress sharing device, especially of an interlocking device, where the distance screws are usually removed. In such cases, it is usually an indicator to initiate partial weight bearing if there has not been any weight bearing initiated already. But of course, you should find it out from the surgeon and then start on progress with the weight bearing. For a stress shielding device, it's a standardized almost 2.5, 3 months of non-weight bearing that is performed. Okay, then we had gone on to non-weight bearing. As I said, as soon as the patient is medically stable, brain is removed, you can initiate non-weight bearing if they fulfill the other prerequisites. And partial weight bearing is as indicated by the surgeon. And I think we had discussed about the percentage. So if the patient is told that they are allowed only say 25%, 40%, then ideally one needs to train the individual with the use of a bathroom scale, wherein they are trained with initially eyes open, so a proper calculation of the weight that can pass through the lower extremity is made, and then they are trained on the scale with eyes open and later with eyes closed, so that they replicate and reach the same on the indicator in the weight scale. And that is how they should progress. So be it whatever kind of assistive device that they are using, this is ideally how it should be done. This is far from so it usually does not take place in clinical situations, but that is how ideally we should go. And I think here is where we had started discussing about non-weight bearing and partial weight bearing gaits. Remember, we had spoken in non-weight bearing as you all had said 3-point gait, right? Yeah, because there is a little discrepancy as musculo understanding and kinesio understanding. So essentially, all non-weight bearing gait will be a swing to or a swing through. Okay, I'm not contradicting anything that has been taught in kinesiotherapy, but just understand that even if you have 3 points on the ground, like it has been told to you in any non-weight bearing gait, for example, say my right lower extremity is fractured and the left lower extremity and say the 2 crutches are on the floor, and that is why it becomes a 3-point gait. Okay, essentially I'm going to perform a swing to or a swing through gait. Correct me if I'm wrong and let me know if you have understood this.
Yes, ma'am.
Yeah, yes, okay. Yeah. So that is how the gait would be. It would be swing to or swing through. And when it comes to partial weight bearing, you are referring to all 4 points or all 4 both the crutches as well as both the lower extremities which are placed on the ground. To a variable extent, weight is passing through the lower extremity which is affected. Okay, so the patient is essentially likely to have 3 types of gait here. One is the 4-point gait. Okay, second is the 3-point gait, and the third is the 2-point gait. I will explain to you how that is. Okay, so for the same right lower extremity fracture that I have, okay, a 4-point gait would be left crutch, right lower extremity, right crutch, left lower extremity. So at any given point in time, there are 4 points which are always in contact with the ground. Okay, and this would by far be the slowest gait because we are taking only one, uh, maybe one crutch or one lower extremity ahead at a time. Okay, so this is the slowest of the gates, and thereby it is the most stable of the gates. Okay, so I'm giving this to you because this would also help you decide what type of gait in partial weight bearing is what